Hi, ladies and gentlemen. This is Dr. Novoa. Today I wanted to talk about the potential financial incentives for placing the Essure device, as well as what's been going on in the past week with articles that have been written on the follow-up or the response to the FDA's request for the black box warning and the patient checklist to be used. Now, as I wanted to stress, the FDA, despite 1 year of review and careful consideration after the September 2015 meeting, where dozens of experts, as well as lay people, women, dozens of women that were hurt by the device, came to Maryland and asked that the Essure device be removed. The FDA came up with the black box warning request and the patient checklist. Now, I say this as a request because, bottom line, the black box warning and the patient checklist does not have to be disseminated. It is not a requirement. It is not mandatory. And therefore, doctors pick and choose what part of the black box warning they want to talk about and what part of the checklist they want to talk about. And the FDA was fully aware of that this was going to happen, that their black box warning, just like in dozens of other cases, has no teeth behind it. It doesn't in any way have any merit as far as trying to control or help the situation. And the FDA knows this. So let's look at the two biggest groups related to trying to help women. And that's going to be Planned Parenthood and the American College of Obstetricians and Gynecologists. From the start, both of these organizations did not want the Essure device to be pulled off the market, and for a variety of reasons, but I'll get to what I believe to be a financial situation or financial incentive for those. But what we're looking at since the black box warning came out, as well as the patient checklist, is that in a recent New York Times article, Planned Parenthood was quoted as saying that they are going to discuss the things on the patient checklist, but are not going to have the patients actually sign the checklist. So what does that mean? Okay, so are you telling me that as a patient, you're going to be informed, but you're not going to be given any proof of what's been talked about? As a doctor, I'm required, if I'm going to do a procedure on you, I'm required to have you sign off on an informed consent. That's the proof that shows that I discussed the risks, benefits, indications, and alternatives of procedure with you. So Planned Parenthood has come out and said, hey, listen, we're going to talk to our patients about potential problems with the Essure device, but we're not going to have them sign anything similar to the patient checklist, or we're going to come up with our own. So I'm very, very concerned and really dumbfounded as to why, after 1 year of extensive discussion and compromise, the FDA comes out with a patient checklist, and Planned Parenthood says that it's not going to require anyone to sign, or patients to sign this checklist. So I just don't understand. What does Planned Parenthood think it's doing, and why does it think that it's better than the FDA as far as being able to provide information to patients, especially after all of the research, all of the time, literally hundreds, if not millions of dollars that FDA spent on trying to come up with this black box warning and this patient checklist. And what the bottom line is that since it's not mandatory, whoever, including Planned Parenthood, can decide whatever they want to do as far as disseminating this information. But let me make something very, very clear, not only to Planned Parenthood, but to the ACOG. Before, where you could say that you didn't know about what the potential issues were, before where you could say that there wasn't enough research and that these were all anecdotal issues, you can't say that anymore. If you don't follow the patient checklist or something very similar to it, you basically are not getting informed consent. And if you're not getting informed consent, every single patient that is harmed in any way by the placement of the Essure device or complication related to the Essure device, and it wasn't in a written form that was very similar to what the FDA has documented, you're going to get yourself in trouble. You're going to find yourself in lawsuits. And it's because you are falling below the standard of care. So I strongly encourage Planned Parenthood, as well as the ACOG, to follow the black box warning, to disseminate this information, to disseminate the information on the patient checklist, and to get it signed and placed in the patient's chart. Now, why wouldn't Planned Parenthood or ACOG want to do this? Very, very simple. There is so much negative information, which is actually true, but so much negative information in the black box warning as well as the patient checklist that it basically will scare almost every single patient from not having the Essure device placed. I don't know very many women that would feel comfortable having the Essure device placed if they knew what the black box warning says or what's in the patient checklist. Mind you, neither one of these includes any information about the Class 3 protection the Essure device has. What is Class 3 protection? Preemption. That basically says, because the FDA has approved this device under a special class of protection, if you are harmed by the Essure device, you cannot sue the manufacturer for any harm that is caused by the Essure device, because it is protected by a Class 3 preemption clause or protection, a law that preempts state laws. So this is at the federal level. This is not in the black box warning, and it's not in the patient checklist. So I don't understand how, I understand why it's not there, but I understand, at the same time I say, why isn't it there? If it was me, if I was a patient, I'd like to know everything about a device to make an informed consent, an informed decision before I have the device placed. And not having Class 3 documented in the black box warning or in the patient checklist, to me, falls below the standard of care. But I say again, now that the FDA has come out with some type of guidelines, some type of information, if any organization or any doctor falls below those standards, you can't claim ignorance any longer. You can't claim to be protected. You are not going to be able to win a lawsuit when patients are harmed by this device. So take it as a warning. Use the patient checklist. Use it as a minimum and add to it. And you better get it in writing that a patient has been informed, because you're not going to be able to win in lawsuits if you keep doing anything like this. That's my comment related to that. Next, I'd like to move on to a question about financial incentive. How did the Essure device get so popular so fast? And I hate to be cynical about it, but let's basically say how the facts are. There was a lot of information disseminated starting in 2008 about the cost of the Essure device and the benefits related to using it. There's also been some allegations that there was a financial incentive to motivate doctors to actually buy in bulk, or to they were getting special equipment that was worth thousands of dollars to be able to place the Essure device. And this was one financial incentive for placing the device. Let me tell you what the real financial incentive is for placing the Essure device, putting aside whatever you think about the benefits of the device. To place the device costs anywhere between $1,200 and $1,500. The compensation, because it's done in a doctor's office in general, is going to be about $3,000. So for a 10-minute procedure, a doctor is going to make, for each Essure device placed, is going to make approximately $1,500. That's 10 minutes, $1,500, or $150 a minute for work that a doctor gets paid for doing this in an office setting. Now, compare that to a traditional laparoscopic procedure. If I were to do a tubal ligation in the hospital, you have to consider the fact that I have to drive to the hospital, I have to evaluate the patient, I have to wait for the OR to get ready, I have to do the procedure itself, I have to evaluate the patient after the procedure is done, and then I'm going to have to follow up with that patient once or twice in my office and drive back to the office. So we're looking at maybe 1 to 2 hours. In the 1 to 2 hour period of time, I'm going to get paid approximately $300 for a tubal ligation done laparoscopically. So I've now spent 2 hours of my time, and I'm getting paid $300. Now let's compare that now. So for the Essure device that I could do in my office for 10 minutes, I'm going to get paid $150 a minute. Or for the traditional laparoscopic tubal ligation, I'm going to get paid $150 an hour. Where's the financial incentive in doing the Essure device? There's the financial incentive for doing the Essure device. Now you can come up and say that, hey, listen, it's a better procedure because it has lower complication rates. Well, we've already shown that it doesn't have lower complication rates than traditional tubal ligation. What about failure rates? Well, I've done over 1,000 tubal ligations laparoscopically, and when I've done it as a burning of the tubes or fulguration, cauterization of the tubes and the entire tube, I've never had a failure. So I have, in 1,000 procedures, never had a failure. And so, to me, I rarely hear that there's a failure when you're doing a traditional tubal ligation laparoscopically. So when you compare another procedure like the Essure that says, hey, listen, you have a failure rate of 1 in 1,000 or 1 in 500, that doesn't really impress me. But what is going to impress me, or what has impressed a lot of doctors, is that I'm going to get paid $150 a minute to do this procedure in my office. I can have my cup of coffee, I can go in and do a 10-minute procedure, and I'm good to go. Okay, so let's not eliminate the elephant in the room. And for all of you ladies that want to know how we're getting paid, that's how we're getting paid. Now, how do we compare that to other procedures? If I do a hysterectomy and I'm being paid by Medicaid, I'm going to get paid anywhere between $300 and $500 for a 1 to 2 hour procedure of it doing a hysterectomy. So again, compare that to the Essure device, tubal ligation, tubal sterilization done in the office. Again, I'm going to get paid $100 to $200 per hour for a much more complicated hysterectomy, or do I get paid $150 a minute to do an Essure procedure? And this was a very, very strong motivation and a selling point by the manufacturer representatives that would come to the doctor's offices and say, listen, I've got this new procedure for you, and it's selling like hotcakes. It has a very low complication rate, very low failure rate, and by the way, you're going to get paid $1,500 for a 10-minute procedure. What do you say? Boom. Thousands of doctors signed on for that. Now, everybody's running for the hills because nobody wants to take responsibility for the complications that have been associated with these devices. So I understand where your anger may be. I understand where my frustration is to try to get the message out. Now that we found that there are problems with the device, nobody's taking responsibility for it. But if you wanted to know how it all started, and you wanted to know how we're getting paid and how much we're getting paid, that's how it all started, and that's how we're getting paid for this device. Tomorrow or in a few days, I'd like to talk about other complications related to the Essure, including a very, very traumatizing, on top of all the traumatizing issues that are associated with Essure, is what we've been seeing a lot of are complications related to people's teeth. A lot of women are getting a lot of cavities or actually losing their teeth from complications that appear to be associated with having the Essure device in place. That's enough for today. I appreciate your time. Thank you very much.